Yes, we can.
Okay. Right. First, I have to give a small announcement to the postgraduate trainees in chemical pathology. After finishing this webinar lecture, please stay with the meeting because we have to give some important announcement. Right. So we'll start and welcome you all to the webinar of today under the topic of evaluation of liver biochemistry. It is my duty to introduce today's speaker, Dr. Chathura Lakmal Piyarathna, consultant gastroenterologist and hepatologist from National Hospital, Kandy. And Dr. Chathura has completed his undergraduate studies from University of Piyarathna and obtained his MD from University of Colombo. And he obtained MRCP, MPCPS, and MRCPE. Then he worked as a clinical fellow at Attenborough Hospital, University of Cambridge. Then he worked at Guy's St. Thomas Hospital, London. He also, after completion his foreign studies, he worked as a consultant gastroenterologist at Teaching Hospital, Anuradhapura, and District General Hospital, Kekol as well. Currently, he is working as a consultant gastroenterologist and hepatologist at National Hospital, Kandy. He has a special interest in non-alcoholic fatty liver disease, cirrhosis, and also on liver transplant functional gastrointestinal disorders. So he always works in collaboration with chemical pathology laboratory, especially during the process of liver transplantation. So I think this is a very good opportunity to discuss any problems or clarifications related to the gastroenterology. So I hope that all the trainees will use this opportunity and you can ask questions at the end of the lecture and also can post questions in the chat box. So without taking further time, I invite Dr. Chathura to deliver his lecture on evaluation of liver biochemistry.
Thank you, Dr. Dulani. So good afternoon to everybody. I hope that you can see my slides.
Yes, Chathura, yes.
All right. So today's, I must thank, first of all, I must thank Ceylon College of Chemical Pathology of Sri Lanka giving me this opportunity to discuss about the evaluation of liver biochemistry. So this is going to be a case-based discussion. So first of all, I'll give some case scenarios to everybody to think about the few possibilities of these cases which I have managed in the past few years. So, and then I will talk about the liver biochemical tests separately. And then we will discuss what are the best options for these cases. And then end of the talk, I think as Dr. Dulani said, you can ask me any questions if there is any. So, case number one. So this is a 35-year-old male came to my clinic on a routine medical checkup. He was found to have these abnormalities of liver tests. So you can go through for a few seconds and then I'll move to the next one. So while you going through these reports, and you can think about what may be the possibilities. And the case number two, it's a 28-year-old previously healthy patient who was an occasional alcohol consumer, admitted following a road traffic accident and had these biochemical abnormalities during the routine blood tests. So you can see some liver test abnormalities, and all the other blood tests were normal except that the impaired blood glucose level. And the ultrasound they did, they found he was found to have a grade 1 fatty liver. So what are the possibilities? So the case number three, She's a 57-year-old female with obese, having some comorbidities, diabetes, high lipids, and the high blood pressure. These are routine clinic visits, biochemistry. Especially, I have mentioned the liver biochemical tests, and just look at the other test as well, because in the interpretation they might also have some values. So this is case number 4. Is a bit different patient. So he's obese male. He was a frequent alcohol consumer. So if you look at the liver test compared to the previous cases, so he has got some significant liver involvement, but see the pattern of the liver enzymes, and then it might need in your interpretation. So the case number 5 is a previously healthy patient coming with a jaundice and the pruritus and a history of fever 3 weeks before. So the AST and ALT more than 1000 range with elevated bilirubin and even the alkaline phosphatase, which was slightly elevated. And his INR is normal, full blood count normal, and the ultrasound we couldn't find any abnormality. So what may be the possibilities? And this is a 17-year-old girl, previously healthy, but recent onset difficulty in writing and poor school performance. So history is important here. And then we found some liver test abnormality, including the bilirubin. And she was having low hemoglobin as well, and the thrombocytopenia. And the liver shows some slightly ecogenic pattern with a prominent spleen. Is 17-year-old girl. 35-year-old female on thyroxine. We just did the liver test, found to have a significant liver involvement, but other basic things were normal. So what are the possibilities? This is again a 55-year-old obese female, which was referred by a rheumatologist with other comorbidities, found to have liver abnormal tests, and then we have planned out a management. So what are the possibilities? So these are the common referrals we used to get to liver clinic in our day-to-day practice. So this is a different one, which we were called to see a patient in the ICU, admitted following complicated MI complicated with the heart failure, found a significant transaminitis, where other serologies were negative. So these are my last case scenario. So the 63-year-old smoker, alcoholic, coming with leg edema, mild abdominal distension, and are found to have abnormal liver. So one of the most common referral to our liver clinic. So this overview of my talk. I hope that you have gone through, but I don't think that you have enough time to think about, but we will discuss while proceeding. So I will give an introduction, and then I'll discuss about the individual test, and then we'll talk about when we should do the liver blood test, and then the how do you clinically identify those abnormalities, and then I'll discuss about the case scenario which I mentioned earlier, and then we will take questions if there's any. Actually, if you ask for a liver function, then that's actually a misnomer, because you know that one thing is the liver function doesn't mean all the liver panel. Actually, I should tell you the correct term for that should be like liver panel or the liver profile. I think Dr. Dulani agreed with me that, because we usually, if we ask for a liver function test, conventionally we think that the SGPT, SGOT only, but it's not. If you talk about the liver function test, we usually think about all the liver tests, including the synthetic function. But if somebody asks for a liver function test, we used to do all the liver tests, including liver enzymes, like AST-ALT, and then the ALP gamma GT, and the synthetic functions, including bilirubin, albumin, and the INR. Historically, we think that it predominantly relates to not to the liver dysfunction, but to elevation of the hepatobiliary liver enzymes, also important in the patient management. So, if you do the liver blood test, you will be able to distinguish whether there is any significant liver disorder. And in addition, we can assess severity and the progression of the liver disease. And then we can monitor the therapy, at least in some diseases. So, as I mentioned you earlier, in red letters, you can see that the liver function test. So, it includes albumin, bilirubin, maybe fractionated bilirubin like total or the direct fraction, and then the prothrombin. So those are called the liver synthetic tests. Aminotransferases are very important. I will discuss what is the importance and how to interpret those things. And then in addition, the ALP and gamma GT are also important in some cases. But if you ask for a liver panel or the liver profile, it should include all these groups, including hepatocellular as well as the cholestatic function. So if you get a patient with abnormal LFT, history is very important, because what they say is, if you get a good history and if you do the basic liver test, you should be able to identify the diseases at least to the extent like 90 to 95%. Because you don't need any very advanced test to find out the common things, but you might have to ask for some additional tests in very seldom cases. So important to identify whether it's acute or chronic. So what the book says is that if the abnormal liver test going for more than 3 months, we usually call that they are having the chronic diseases, not the acute ones. And then you should be able to get a history regarding whether the patient is asymptomatic or symptomatic. Because most of the time, what happens is that the patient, if they ask for a test for insurance purposes, they will have a abnormal biochemistry, especially the liver biochemistry. And then they will self-referred or somebody will refer as an outpatient. So it's very important that to ask about whether the patient is asymptomatic or symptomatic, because sometimes you might not need to do any additional test and you can just follow them up with the repeat liver test. And then to identify whether there's a recent insult to the liver, like you have to get the history about the liver toxic agents like alcohol, medications, especially antibiotic group, and then the toxins, and then whether there's any hypotensive episode in inward patients, and then the pregnancy status, and then the past history of gallstone. I have mentioned herbs here in a different color because I think it is something like which is very important, but we, to some extent, at least we neglect. The patient also thinks that those are not very important to tell to the doctor. And some of our doctors think that those won't cause any problem. But when it comes to the liver, herbs are very important, at least in this part of the world, because they say that herbs or the herbal drug supplement, which is called HDS, are very important in the liver abnormality, because we don't know what it contains and the patient don't know what they are taking, and they think that those are very good for their health. Sometimes people will take herbs over the counter medicines, like so. I think I usually ask them whether they have taken any herbal medicines or the herbal preparation, and then to ask about the history about the hepatitis. And then in the history, we can, to some extent, we can get to know that whether this is abnormality is hepatitic or the cholestatic. I know that you all know that the AST and ALT are referred to the liver hepatocellular injury. Cholestatic things are, we can get the idea by doing the ALP and the gamma GT, because those are excreted by the liver hepatobiliary endothelium. And then the other thing is magnitude of the enzyme elevation. Sometimes your liver enzymes is more than the 10 times of the normal level. So in that case, you know that there's an acute insult to the liver, which is important in the management. But it won't, all the time, it won't predict the outcome, the significance of elevation. Okay. And then the rate of change. And then the nature of the cause of the abnormality, whether it's a mild fluctuation or the progressive disease. And then I'll go to each biochemical test separately. So the first I will discuss about albumin, which is synthesized exclusively in the liver as a marker of the synthetic function, which is very important. You know that the half-life of albumin is 3 weeks. So, and the daily production is 0.2 gram per kg. So there are multiple biological actions of albumin, which is a very important synthetic function when it comes to the liver test. Because you know in the intravascular component, and it binds to a lot of substances, including bilirubin, thyroid hormone, drugs, fatty acids. And if there is a hypoalbuminemia, the patient will get a lot of clinical manifestation. And then sometimes the metabolism of compounds like lipids, and it has got antioxidant property. For example, if you get a cirrhotic patient, if they get ascites, if they have, usually they will have the low albumin. They said that if you have hypoalbuminemia, the chance of getting the spontaneous bacterial peritonitis is very high, significantly high, because albumin has got antioxidant properties, which prevents them getting infection. And albumin is a negative phase reactant. So, for example, like CRP, that is a positive phase reactant. If you get an sepsis, you will get an elevation of CRP. In contrast, albumin will be low in sepsis. And if there's a SIRS, like systemic inflammatory disorders, they will have the low albumin for a temporary period. And following the resolution of sepsis, they will have the normal albumin level. And then if there's a nephrotic syndrome or the cirrhosis, they used to have low albumin. And then if there's a malabsorption of protein-losing enteropathy. So those are the causes for reduced albumin in patients. What about bilirubin? So bilirubin is also next synthetic function, which we import in the liver test. So it derives mainly from hemoglobin, and the normal value is 1 milligram per deciliter. And there are two forms. One is a direct, which is conjugated form, and other one is an unconjugated indirect bilirubin. So patient will experience jaundice or the icterus if they have got bilirubin more than 3 milligram per deciliter. I won't go into the details about here because I don't think that is relevant to you. So if there's a direct, so what about the direct bilirubin, which is conjugated, water soluble, so which you can see in urine. So what are the causes for direct bilirubinemia? So if there's a hepatocellular injury, or if there's a biliary obstruction, you will see direct hyperbilirubinemia. And there are other causes which can cause, I will discuss it. And then the indirect bilirubin, which is unconjugated, and it's water insoluble, only lipid soluble. So you can't see in urine. And if there's a hemolysis or hepatocellular disease, you might see elevation of indirect bilirubin. So there are many mechanisms that hyperbilirubinemia. For example, if there's a hemolysis, that is, you will get the high bilirubin because increased delivery to hepatocyte, which they can't manage. So you can see the high indirect bilirubin in the blood. And then there's just a reduced uptake by hepatocyte, like shunts. There's a shunts or the drugs like sulfur, which can affect the uptake of bilirubin into the hepatocyte. And then if there's a problem with the transport within the hepatocyte, like there are some genetic causes or the drugs which can affect, you can still see the hyperbilirubinemia. And then if there's a molecular alteration in hepatocytes, like there are some genetic causes, which I will discuss. And then if there's a problem with the secretion into the bile, like cell damage or the other genetic causes. And if there's obstruction, you know that it will prevent them going into the enterohepatic circulation, and it will collect in the circulation, I mean the blood. And you can, if you do the liver panel with the fractionated bilirubin, you can see the hyperbilirubinemia. So what are the causes for unconjugated thing? As I discussed, if there's a hemolysis, if there's ineffective erythropoiesis, or if there's a excessive blood transfusion, if there's a resorption hematoma, those are the causes of unconjugated hyperbilirubinemia. What are the causes of decreased hepatic uptake, which give in the indirect hyperbilirubinemia? The commonest is a Gilbert syndrome, and drugs like rifampicin also can cause priority. Conjugated one, mainly the genetic causes like Dubin-Johnson syndrome and the Rotter's syndrome. So those are the causes for hyperbilirubinemia. So the Gilbert syndrome, that is one of the most common cause of an isolated elevated bilirubin. Prevalence-wise, like 5 to 10% of the normal population, and that is one of the most common referral to liver clinic with the abnormal bilirubin level, but all the other liver tests are normal. So you know that it's like a diagnosis by exclusion. As far as I know, there is no proper, at least a common test to identify Gilbert syndrome unless you assess the enzyme level, which is reduced in these kind of patients. You know that it exacerbates during fasting, infection, dehydration of certain drugs, but it usually doesn't exceed the level 4 to 5 milligram per deciliter. So if it is more than like 10 milligram per deciliter, it's very unlikely to be a Gilbert syndrome. It should be something else plus Gilbert, if at all. So these are one of the other most important liver tests. So the aminotransferases, you know that there are two enzymes, important enzymes. So the one is ALT, which is almost exclusively from hepatocyte. They separate from hepatocytes. It's very specific to the liver injury. It's more sensitive and specific than AST. That's also very important. And the half-life is 48 hours. And the normal value, it's not the lab value. These are the reference laid down by the guidelines. So the normal value for at least for hepatologists, ALT is 27 for male and the 19 for female. But I know that the most of the lab, they give the reference like 40 international levels, which we usually don't rely. So if somebody has the 40 mean, actually it is, among female, it likes a double the normal value. So values we are thinking is much lesser than the value in the lab report. So this is very important. So when it comes to AST, you know that it is in a cytosol as well as the mitochondria, but it's not liver specific because AST can be found in liver, heart, skeletal muscle, kidney, brain, pancreas, lung, WBC, RBC, even bone. So if there's elevation of AST, you know that it's not only the liver. You might have to find out the other causes. And the half-life is just 24 hours. But it's more sensitive indicator for alcohol-related injury rather than the any other cause. So the normal value is like up to 35 international ml per liter. So this slide is, I think, for you guys, it's important because one thing I want to express upon here, the half-life. So the ALT. So if you take a normal healthy person, their ALT is always more than the AST. That is because one thing is a half-life. So the half-life 48 hours is that if you reduce the ALT today by the hepatocyte, it will be there for 48 hours. In compared to the AST, which is there in the circulation only for 24 hours. So if you just get a blood test to check for ALT and AST in a healthy person, It's always ALT more than the AST. Why I'm stressing upon that? So there are some conditions which can cause AST more than ALT. So one of the most common condition is a cirrhosis. So you can see in this graph, so that is called the hit and run pattern of liver enzyme. So if there's an injury, what happens is AST elevation is there more than the ALT level, but it goes away within a daytime. But ALT will be there for 2 days. So we all know amine transferases elevated in nearly all liver disorders, but the pattern is what we expect is ALT more than AST all the time, except there are some conditions. So the AST-ALT normally ratio is 0.8. That means ALT more than AST. And it rises in hepatocellular injury markedly. But you remember the levels may or may not reflect the severity of injury. So usually we don't rely, the level doesn't predict the outcome, as I told you earlier, because sometimes the level may be like 10,000, but the patient might recover completely. But sometimes the patient's value may be less than 100, but still they have a permanent liver injury. So you never correlate with the final outcome, the level. So you should always remember the pattern and the what is the trend pattern. So if there's an acute hepatocellular disorder, we expect to have the high ALT in a patient than AST. If there's a viral hepatitis and the non-alcoholic fatty liver disease, AST-ALT ratio typically less than 1. But as I told you, when there's a cirrhosis, the pattern reverses. So the AST will be more than the ALT. So there are a lot of theories about that. So one thing is a half-life. So AST half-life is 24 hours, ALT half-life is 48 hours. So ALT will be there in the circulation to a great extent compared to the AST. And the other thing is the vitamin B6. What happens is a cirrhosis, vitamin B6 is depleted. So to produce the ALT, you need B6. So if there's a deficiency, the ALT production is less compared to the AST. So they will have the high AST. So the alcoholic related liver disease, usually the pattern is reversed. So the AST-ALT ratio like 2 to 1. So that means that it is very suggestive of the alcoholic related thing. But the levels rarely exceed 300. So if you suspect any alcoholic hepatitis, you won't expect them to be more than 300, and the ALT usually often normal. And so this is what I have told you. So relative low ALT in ARLT due to deficiency of vitamin B6. There are other theories why it is low. And the other thing is in alcohol abstinence, at least you might have to wait 1 to 3 months to be normalized. So you don't repeat it very soon. You have to wait at least 3 months to normalize those liver tests. So that's why we are following them up maybe like 6 weeks or the 3 months time, because it takes some time. So this is a graph which chemical pathologists are very concerned. So these are normal values. When it comes to the cirrhosis, it won't exceed like 600s. But if there's a fatty liver disease, it might go up to 200 level. And if there's an acute alcohol insult to the liver, it might reach 1000. But if the liver enzymes are more than 1000, so there are few conditions like autoimmune hepatitis, acute viral hepatitis, or the toxic hepatitis, or the ischemic hepatitis. So then if you do a basic liver panel, we can get an idea about what it is going to be like. Because if it is less than, the 100, you won't think about ischemic hepatitis. But if it is like 5,000, 6,000, you won't think about the cirrhosis per se. Because by definition, you know that if there's a cirrhosis, there's no enough cell to produce the liver enzyme. So you won't expect very high level of liver enzymes in a cirrhotic patient, because basically there is no cell to produce that. So these are the common etiologies for the transaminasemia. So there's a term called transaminity. So what does that mean? Is that if you see an elevation of liver enzymes due to an inflammatory cause, usually tell them as the patient is having a transaminitis. So these are the causes for transaminitis. So the most common thing is alcohol, and then the NSAID, which is a very common drug, and then the HMG-CoA reductase inhibitors, as the book says, but we rarely see in that the study the lipid lowering drugs causing liver the liver transaminitis, and the liver failure is extremely uncommon. What they say is like a 0.01% like. So I usually want follow them up with liver enzyme if they have put on a study which was done few years back. So hepatologists usually don't recommend to do liver enzyme for follow up of at least a statin-induced liver injury. We never recommend unless there's an indication, like cases of hypothyroidism or the cases of previous liver injury. In that those cases only, we'll ask them to do a repeat liver test. And then anti-epileptic drugs, anti-tuberculous drugs, those are very common to give rise liver transaminitis. And then the herbal medication and the illicit drugs. And the non-alcoholic steatohepatitis, the one of the most common condition which can give rise to mild transaminitis. And then the chronic hepatitis B and C, it's not very common in this part of the world, but in the Western, it's one of the most common viral infection which can give rise the liver transaminitis. And then the autoimmune diseases like autoimmune hepatitis, primary biliary cholangitis, and then the hemochromatosis, Wilson disease. So those are the diseases which can cause liver transaminitis. Endocrine diseases like hypothyroidism, Addison's disease also can give rise to this abnormal. So the amino transferases. So if there's a compensated chronic liver disease, which means that they don't have any complications like ascites, jaundice, or encephalopathy, they will have a normal or mildly elevated liver enzyme. But the important thing is the pattern. AST more than the ALT. And the NAFL fatty liver disease cases, as usual, ALT more than the AST. So if there's a level more than 5 times of the upper limit normal, you have to think about the secondary etiology, like concomitant acute liver injury. So acute viral or toxic hepatitis, it can go up to 25% of times of the upper limit of normal. And the hypoxic ischemic hepatitis, it may be like 10,000, 15,000. So these are some, clues to think about the etiology. Any problems so far? Anything you want to ask? All right. So what about the alkaline phosphatase? In the short term, we used to call it as alkphos. So it's mainly comes from biliary endothelium, and it gives an idea about the cholestasis, because if there's a obstruction in the biliary pathway, it can give rise to elevation of alkaline phosphatase. But keep in mind, it's not specific to the liver. Even in commonly, if there's a bone pathology, like a fracture, or even during the bone growth, it can be elevated. And during the pregnancy, because it's secreted by the placenta, you will have the high level of alkaline phosphatase, which is physiological. And then the intestinal problem or the kidney issues also, they said that you can have the high level of alkaline phosphatase. Half-life is 1 week, and it rises in late in biliary obstruction and decreases slowly after resolution. So if there is a hepatocyte injury, and biliary obstruction, you can have the elevated alky pos. And if there's extra intrahepatic cholestasis, you will have a marked elevation of like 10 times of the upper limit of normal level of alky pos. So by the magnitude elevation, you can get an idea that whether it's a hepatocellular or cholestatic or mixed. So these are the causes for elevation of alky pos. I don't want to go in detail for that. And the other important test is the gamma glutamyl transpeptidase, which is called gamma GT, GGT. So it's an important enzyme for transpeptidation, and it's a more sensitive biomarker for many liver pathologies, but it's again not specific, and it can be elevated in response to oxidative stress and the glutathione depletion, like in paracetamol toxicity. The gamma GT level can go up. And it is an indirect biomarker for cardiovascular and metabolic risk because it is associated with fatty liver disease. It's again the liver manifestation of metabolic syndrome. So it can be elevated. So the important thing about this cholestatic enzyme, so when it combines with ALP, so if there's an ALP plus gamma GT elevation, you know that's it's a liver origin. That it may be a liver injury. But if only alkaline phosphatase with normal gamma GT level, you know that it's very unlikely to be a liver thing. It may be something like bone disease. So that is the importance of doing alkaline phosphatase. I know that being chemical pathologist, you very want to do the isoenzyme of alkaline phosphatase. But as far as I know, that it doesn't have much value when it comes to the isoenzyme of alkaline phosphatase. Rather than that, you can easily do the gamma GT to find out whether it is liver origin or the bone origin. So other synthetic function test would be the prothrombin time. It is important in the coagulation cascade because it needs a lot of enzyme, the protein factors to affect the prothrombin time, mainly the liver origin one. And the prothrombin time, the INR elevated is a reflection of the decreased synthetic activity going with the albumin and the bilirubin level. So if there's a liver problem like which can cause vitamin K deficiency, fat malabsorption, of the chronic cholestasis, you can have the high prothrombin time with the high INR. So sometimes there may be congenital deficiencies, conditions like DIC, drugs like warfarin also can cause high INR. So if a patient has got a lot of synthetic abnormalities like high INR, high bilirubin, and high albumin, you know that the patient is having a chronic liver issue. So when should we ask for a liver test? So if you get a patient with a non-specific symptom, because you know that the liver disease tends to develop silently with no signs or symptoms. What we know is that up to 80% of the liver damage you can compensate or tolerate. So if you exceed the liver injury more than the 80% of the level of the capacity, then only you will get the symptoms. So that's what we are telling that if the patient is having a non-specific symptom, if you can't find any abnormality, do a liver panel, find out whether the patient is having any liver problem. Majority of people with late-stage liver disease are undiagnosed, and the 75% of the patient with AIH, they will have more non-specific symptoms such as fatigue, nausea, and anorexia. So see that which is a very treatable condition, but again comes with a very non-specific symptoms. Most of the time, the females are get these kind of illnesses, which they think that it's a normal aging process. So, but without doing the liver biochemistry, you can't find out whether they have any significant liver involvement. And the other condition is if you clinically think that the clinical, if the patient is having clinical evidence of cirrhosis, you must do the liver test. And then there are some other conditions like pre-existing autoimmune diseases, inflammatory bowel diseases, which can complicate with the liver involvement. So in that case, you must do the liver. And if you are using liver toxic drugs on a patient on a regular basis, like carbamazepine, methyl-dopa, statin, sulfonamide, chlorpromazine, methotrexate, then you will need to do the screening liver test, and then once in a way you have to do a liver profile to see whether there is any drug-induced liver injury. We usually call it DILI, drug-induced liver injury. So then when should liver blood test to be checked? When there is a family history of liver disease, like Wilson, hemochromatosis, cryptogenic cirrhosis, you must do liver test on family members to find out as a screening method, to find out liver diseases at an early stage. And then if there's a high risk groups of viral hepatitis, like IV drug users, prisoners, commercial sex workers, migrants from high prevalent areas, and then we used to do screening liver biochemistry. And then the presence of metabolic syndrome, that is what they say is, now the recommendation is, if you find one metabolic syndrome disease like diabetes, hypertension, or dyslipidemia, you must do the liver panel or the liver profile as a screening test to find out or they exclude fatty liver disease, which is very common. So this is very good slide, but it's congested. I don't know whether you can see it properly. So the clinical pattern, as I told you, so you have to get a proper history, and then you have to identify, you have to have a suspicious what it could be. Suppose if the patient is having hepatic transaminitis, then you have to do the other liver test, plus or minus ultrasound. And then if you can't find any abnormality, you should order these non-invasive liver screening, which includes hepatitis B and C, autoantibodies like anti-smooth muscle antibody, immunoglobulin G level, and the ferritin transferrin saturation, and the other metabolic screening, and the Wilson. For Wilson, we'll do the serum cellular plasma. Suppose if all negative, and if the ultrasound said the fatty liver disease, we can manage them as a non-alcoholic fatty liver disease in the settings of, without any history of significant alcohol intake. And if it doesn't show any fatty liver on scanning, then you need to think about the other secondary investigation set, which includes some of the invasive tests like liver biopsy. And if there's a synthetic failure, you know that it's not acute, like jaundice, low albumin, problem INR, then you should refer them for a tertiary care center, because they might need biopsy or the invasive test, because you know that the patient is having the chronic disease. And then if there's isolated price bilirubin, as I told you, it may be direct bilirubin or the indirect bilirubin. Again, you need to do the other blood test to exclude the other causes like hemolysis, where you can ask for a reticulocyte count, LDH, or the haptoglobin. If those are normal, you can safely convince the patient that you are having indirect hypobilirubinemia or the unconjugated thing, which does not cause any chronic liver ailment. So you can just reassure them, because it's also very important, because otherwise they will go to a different physician and they will undergo extensive investigation, because we know that there are some patients who underwent repeated liver biopsy because of the high indirect hypobilirubinemia. Because it's, there's no value. Everything will come as normal, except the high indirect bilirubin. So reassurance is also very important. And then if there's isolated cholestatic liver enzyme like high ALP or gamma DT, you know that you need the imaging and sometimes a biopsy, because it's not normal for a patient to have the persistent high ALP and gamma GT, where we need to refer to a specialist center for a further investigation and management. So this is somewhat a summary about the liver panel. I think you have got some idea about how to interpret and when to refer the patient for a further investigation. So up to now, before I move into the case scenario, any questions regarding the previous slides? I can discuss now.
In the chat box, there is question. Kindly let us know the important ALP levels for children.
Yeah, again, actually, what they say is that it depends on the age and the your body weight. I mean, the age and the gender. It depends on the age. For example, 12-year-old boy comes with the, I will take the normal reference value. I mean, for the adult value, like ALT level. If you ask me the ALT level, I will go for the 19 for female, 27 for a male. But if you ask me less than 5 years, I mean the kid who is younger than 5 years, I want them to take like 27 is a normal for them. So it's much lesser than that, because you know that your liver volume will decide what enzymes level you should have in your blood. So I think it's, again, there's no, I mean, the direct answer, but it depends on the age and the gender. Any other questions, Dr. Dulani?
There's another question. Yes, the total bilirubin is within the reference interval, does not elevate this and elevated direct bilirubin above the reference interval clinically significant.
I didn't get the question, Dr. Dulani. What they are telling is that your reference, I mean, the total level is normal, but your direct fraction was
About
high.
the reference, yeah.
Yeah, so the thing is, conventionally, what we are thinking that the half, I mean, so I think these slides will give you the answer for that. So there are two forms. So conjugated bilirubinemia, there should be a 20% of the total level should be, I mean, there should be a more than 20% of the total of the direct fraction should be there to tell that the patient is having the direct hyperbilirubinemia. If there's a 85% of the total, if it is unconjugated, then only we can say it's a indirect hyperbilirubinemia. But I know that the most of the people, what they say is like a 50%. Suppose your total bilirubin is 2 milligram. If somebody has the 1.5 milligrams of direct fraction, you can say that's a direct hyperbilirubinemia. There are several theories. Some say that it's a more like less than 50%. But what I will take is as this is the correct. So the more than 20% of the total, if there's a direct fraction, I will take that as a direct hyperbilirubinemia. Is that answer to your question, Dr. Dulani?
Yeah, yeah, I think it's clear. And the small clarification, because that in the laboratory, what we give is the reference interval. That is for the 95% of population will be within that range. That is the interval that we given in our reports. I think that you have mentioned the decision cutoff for the male 27 and for the female 19. So I think that will be the reason for that difference.
Yeah, that's what I make it as in the red line, because I know that most of the time.
Important.
Yeah, that's very important. Because what it comes to the, I mean, the patient management, because most of the time people will come and tell us, doctor, see that my reports are within normal range, but you are telling that I have got the fatty liver. So what it could be? So then what I was telling is that this is a machine generated thing, which manually we can't change. So that's the answer. I mean, I always give that answer because otherwise the patient will argue with me because they say that 30 is normal for them. But I used to tell that, especially for the female, when it is 39, they said that it is still within normal range. I used to tell, no, your values is like twice the normal. So like that.
Dr. Chathura, is there any guideline that we can refer for that these decision cutoff?
Yes, yes, there's a guideline. Actually, I forgot to mention it in here. So I'll let you know. Yeah, I'll let you know for the college. Yes, I'll give. There are guidelines. Yeah, very clear guidelines are there.
So I think we can move on to the cases.
Yeah. So we'll go into our first case. So that's a 28-year-old healthy male, 75, bit obese, occasional alcohol consumer. So that's a case 2. So the case 1, sorry. So the 35-year-old male, social drinker, routine medical checkup, found to have the high ALT and the high AST, like 2 times upper limit. And all the other tests are normal, but he has got a mild hypertriglyceridemia with the diabetic range of blood sugar. And the ultrasound grade 2 fatty. So what do you think? So the normal pattern, but the elevated levels. So that's a asymptomatic patient, routine medical checkup. So this is a very good case for a non-alcoholic steatohepatitis, which is very common. So still you have to do the other non-invasive liver screening like Hep B, Hep C, and then maybe serum ferritin or cellular plastin because he is too young. And then if those are negative, you can just then follow up them with the lifestyle modification. We usually won't give any medications in these cases unless your lifestyle modification fails. You repeat these things maybe in 3 to 4 months, and then we'll see how they are going. But unless, if they can't improve these tests at the end of the maybe more than 3 months, then we used to do the secondary test like maybe fibroid scan or the liver biopsy. So here it's not the fatty liver. This is a steatohepatitis because the fatty liver disease is a diagnosis done by the radiologist. This is a NASH because they have got a fatty liver plus transaminitis. That means there's a hepatitis going on. That's why it's called the NASH. So the natural sequel is like normal liver, then the fatty liver disease. If you don't do anything, they will progress into the NASH. The NASH will progress into the cirrhosis or the hepatocellular carcinoma. So that's a natural progression. So case scenario 2, healthy male, young, 75, following RTA. They have got high ALT, high AST, ALP normal, gamma GT bit high, bilirubin is high with the indirect action. You see it carefully. So anyone can answer what it could be. Any guess? So the normal transaminitis pattern elevation. So the ALT more than AST. That means we know that it's unlikely to be a chronic disease. And the gamma GT is a metabolic syndrome marker for the liver at least. And the bilirubin pattern, indirect hyperbilirubinemia, which is very common. So maybe not a single pathology, maybe a dual pathology. So that's a very good case for the NASH plus Gilbert. These are very common in day-to-day practice. So that's why we have to very concerned about when it comes to the interpretation. So this is a case of NASH plus Gilbert syndrome. Because at the end of the day, otherwise, he will end up with a liver biopsy. Because you think that there's a huge liver injury with a high bilirubin fraction and even the liver enzyme. So we might have to do a liver biopsy, but it's not all the time. This is 57, diabetes, dyslipidemia, hypertension, coming with transaminitis again, and see the pattern. So the the AST more than the ALT. So by looking at that, you know that there is a significant thing going in the liver. And if you see the platelet, there's a thrombocytopenia. and the blood sugar is marginally high, and the ultrasound significant fatty liver with the hepatomegaly, but no ischemia. But you know that this pattern is not normal. Okay, so what it could be then? So there should be a chronic insult, no? So that's a NASH-related advanced fibrosis, so the early cirrhosis. So you have to, these patients, you can't manage in the primary care settings. You need to refer to a tertiary care for investigation. She might need a liver biopsy, because it might be NASH cirrhosis or sometimes very rarely autoimmune hepatitis. So that's a very good thing. It's not that elevated, but still the pattern is reverse. So that's important. And this is the next one, 57, obese, frequent alcohol consumer. See the pattern. So the LT84, AST twice the level of ALT, bilirubin is high, albumin low, gamma GT very high, and the alkipos 145. The platelet is low. So by looking at that, you know that even the synthetic functions got abnormal levels. So unless proven otherwise, it's an alcoholic cirrhosis. But what I have put, any guesses why I have put the hepatitis here? So that means, in addition to cirrhosis, there's an acute insult going on. That's why they have got the high AST level and the ALT level. So these are not explained only with the cirrhosis, because cirrhosis, they won't go beyond hundreds unless there's an acute insult, even the bilirubin. So this means, in addition to the chronic element, there's an acute insult going on. So that is probably due to hepatitis, because it's a frequent alcohol consumption. And the striking feature is high gamma GT compared to alkaline percent. So somebody might think this is a cholestatic, but see the pattern. ALP is marginally elevated, but the gamma GT significantly high, maybe five times high the upper limit. So that means alcohol is an inducer for the gamma GT production. So that's alcohol. Alcohol is an enzyme inducer. So that's why they have got the high gamma GT compared to ALP. And then the 22-year-old presented with jaundice with a febrile illness. And the ALT, AST very high. You know that the pattern is again ALT more than the AST. Is acute insult, no chronic element, high bilirubin, everything else is normal. You know that this is acute insult, like a viral hepatitis, most likely the hepatitis A. So enzymes can go up to thousands with the high bili, and the up to 5,000. It's expected to have the 5,000 in the acute setting. 17-year-old girl with learning difficulties and have found to have marginally elevation of liver enzymes with the high bilirubin. INR is marginally elevated, and there is a thrombocytopenia with hemoglobin, low hemoglobin. And the ultrasound shows slightly co-secogenicity. So you know that unless proven otherwise, young girl with the evidence of hemolysis with the liver derangement, you must exclude the possibility of Wilson. So this is a Wilson disease with a cirrhosis. Why we are telling the Wilson disease? Because everything is fitting for that, and there's a element of the hemolysis as well, which is very common. Here, I'm sure that you will know that the Wilson disease, they usually have a low ALP level, significantly low ALP level. So I don't know the reason, but book says that if somebody has the very low ALP level, there's a value called R value, and there's a formula. If they have a very low ALP level, that things works for Wilson, because you expect to have high ALP in a liver disease, but Wilson liver disease, they have a low ALP level. So keep in mind that. And then this one, 35, female, on thyroxine, liver blood test, And this case, autoimmune markers are positive, like anti-smooth muscle antibody positive, IgG level more than the reference range. So you know that the young lady coming with the high levels of transaminases with the element of chronic liver disease, you know that we need to go for the liver biopsy for the confirmation, but at least the differential diagnosis should be autoimmune hepatitis. So the next case, a lot of comorbidities, 55-year-old obese. Actually, these are one of the common, this one was referred by rheumatologist. He was on NTX for 2 years and stopped currently of leptonomide, aspirin, atorvastatin, and appropriate drugs. ALT more than AST, alkaline phosphatase within normal range. Albumin, it's marginally low, gamma GT very high, platelets normal, HbA1c high, lipids normal. So what are the possibilities? So there are several possibilities. So it may be just the NASH because she has got other metabolic syndrome features, and then it may be drug-induced liver injury, maybe due to MTX. Atorvastatin very rarely, but the other DMARDs, and then the autoimmune hepatitis. So those are the possibilities. And the one before the last one, so the 68, diabetes, hypertension, admitted to ICU with MI, complicated with heart failure, very high level of AST, ALT, and the creatinine also high. Scan doesn't show any features of chronic liver disease. Basic other blood stress are normal, and including the other non-invasive liver screen. So you know that if there's a hepatorenal syndrome, like here, you know that it's a systemic involvement, like persistent hypotension, which can cause hypoxic or ischemic hepatitis. So these levels can go up to 10,000. I will show you one case at the last, which I have now at the moment I am managing in the MICU. So this is a case of hypoxic or ischemic hepatitis. So I'm not going to details on management of these patients. I don't think that it's relevant. So the 63 smoker, alcoholic, presented with leg edema and significant ascites. See the pattern. So the ALT is more or less normal, 23, and the AST 28, AST more than ALT, albumin very low, bilirubin high, gamma GT is high, INR is abnormal, and there's a thrombocytopenia. That's a cirrhosis with moderate ascites. So simply, there's no cells to produce the liver enzyme, but still the pattern is important. So the AST is more than ALT. So if you remember that, at least that in my lecture, that's enough. I mean, for the rest, because these patterns, because people will think that my enzyme cells are normal, but they are having end stage, the chronic liver cell disease. So that's the cirrhosis with portal hypertension, but the enzymes levels are normal. I think I have done all the cases, but I want to give one more slides regarding a patient I'm managing at the moment in Candy MICU. Dr. Dulani, can you see the values? It's clear. I just take a snapshot because I didn't have much time to prepare it.
We can see.
All right, good.
Yeah.
Can I enlarge it for a bit? No, that's the maximum. So at least, can you all see the pattern of SGPT and SGOT with the bilirubin? There are alkaline phosphatase and the gamma GT as well. So you can go through. So this was done in 8th. And these are the 8th, 9th, 10th, 11th, and this is the latest. So if somebody can't read it, I will tell. So the SGPT value earlier, at the admission to ICU, 3,500. And the OT, 14,375. So it has gradually come down. Today, it was, the SGPT was 1,498 and the SGOT was 5,400. Bilirubin rising 379 with the direct fraction elevation. Gamma GT 261, alkipos 524. So what do you think? Can somebody tell me the possibilities? So the patient is still in the MICU. Any possibilities? So these are not very uncommon. Actually, this patient was a young army chap. Must be, shall I see his age? 35 years old. See, 35 years old, male, admitted with an acute febrile illness. And one of the physician referred to me with the abnormal LFT. And then we have asked them to do the dengue serology because it's very common. And the dengue serology, IgM positive, IgG negative, NS antigen positive. So initially we thought that is dengue hepatitis. And then we started NAC and the liver failure regime. But I was worried about this elevation. It was not very common to have this much of elevation. And then I have asked for the other non-invasive liver screening like Hep B, Hep C. Maybe I'm not sure whether I have asked for the serum cellular plasma. It's done in outside, but that's serum ferritin. And the Hep A, IgG, IgM came as positive. So that explains this much of elevation. So that's a dual pathology. Any other suggestions that he must be having something else? Anyone? Can it be the ischemic hepatitis? Any possibility of ischemic hepatitis? Yes, it is also there. Now he is on a 1-ionotrope. All right, he was on. So that is also there. So this is like there are several etiologies. So it may be just the dengue, viral hepatitis, or the plus or minus ischemic hepatitis. Because the suggestive feature of the ischemic hepatitis is renal functions are also abnormal. That is a systemic involvement. So if there is ischemia of the kidneys, it will definitely affect the liver as well. So that is a combined pathology. And in addition, see the pattern. So what you expect is a LT more than the AST in the healthy one. But here, see that pattern, AST more than the ALT. That means patient is not doing well. That means he has got a massive cell necrosis. So that's why that means that SGOT production is more than its clearance. So that means SGOT is producing SGOT continuously. That means because of the cell death. So enzyme level comes down, that doesn't mean that he is recovered, because her pattern is totally different what we expect. Suppose if it is like SGPT 5000 and SGOT 1000, I'll be happy. But here the pattern is not very good. The trend is not good because he is having the massive cell necrosis, but at the moment he is on dialysis, hemodialysis, and the plasma exchange to clear out all the toxin. The best thing is in this settings, he needed liver transplant, but overall he's not doing well. So we are still giving his the continuous supportive treatment, heading towards liver transplant. So that's a very good thing, very good indicator of liver involvement. So that's again these things. Anything you want to ask regarding this patient?
So can't it be HLH? Secondary to viral infection.
Yeah, that's a possibility of there, but we won't expect that much of elevation of liver enzyme in that case. It may be a part of it. Yes, it's a good guess, but I don't think that it is alone. Yes, there's a hemoglobin level is also low. The latest one was like 7.7. Yes. I don't know whether it's due to the hemodialysis. It could be, but the liver, at least for the liver, I think he has got the massive cell necrosis. Because INR is high, gamma GT high, alkibos high, so everything is fitting. Any other things? I think that's all I have to tell. So the take-home messages should be like abnormal tests should only be interpreted after review. Good history, basic liver panel, and then the basic imaging, please. And then sometimes you might get a normal, the abnormal liver test, but which you don't need to do anything, like Gilbert syndrome. So it's not very important when it comes to the patient management. And then you always do a etiology screening irrespective of the level and duration of abnormal, because otherwise they will come as a chronic liver cell disease, which is permanent, and you can't do anything. And abnormal refers to an anomaly which is outside the laboratory recurrence rate, which you always remember. And then the patient with abnormal liver test, even with a negative extended liver etiology screening and no risk factors for NAFL, should be referred to a gastroenterologist for further evaluation, because they might need secondary, sometimes invasive liver test like liver biopsy. So thank you very much. I think I have done it. So I can take up any questions if there's any, or otherwise we can finish off.
Yeah.
Thank you. Thanks.
Yeah, and if there is no questions, yeah, I appreciate your contribution for our webinar, Dr. Chathura. I know that you missed your endoscopy workshop as well. So I invite Dr. Dilanti to deliver the vote of thanks before winding up the session.
Thank you, Dr. Dulani. I hope that you all can hear me. Can you all hear me?
Yeah.
Yeah, okay, thank you. Firstly, let me thank Dr. Chathura Lakmal Piyarathna, consultant gastroenterologist and hepatologist, National Hospital, Kandy. Thank you, Dr. Piyarathna, for delivering this interesting and informative presentation and sharing your knowledge and experience with us amidst your busy schedule. So we very much appreciate your contribution today, and we gain a lot of knowledge through your presentation. So thank you very much. Next, I would like to thank all the participants who joined today to make this event a success and making this Q&A session interesting. So we hope to see you all in another interesting webinar like this next time. Until then, goodbye and have a nice day. Thank you.
Thanks. Thank you.